Well, good morning. Happy Friday. I want to welcome everyone to our Chalk Talk. I'm Rachel Gage, and I have the pleasure of introducing Cal Cates. They are one of HealWell's founders and executive director. HealWell is challenging the traditional silos of healthcare disciplines to create distinctive opportunities for interdisciplinary education and practice. We know that they'll go further by creating a broader impact in community, by making the world a better place, but they specifically work on teaching massage therapists to provide care safely and effectively, and they advocate for access to that care and for a broader role for massage therapists in healthcare, which I am a huge advocate for, and I'm looking forward to hearing more about the research and the articles that have been published on this. So welcome, Cal, and I will give you the platform. And for those of you in the audience, please put your questions in the chat and raise your hand, and we'll get to them at the end.
All right. Well, thank you for having me. I think Marty and I plan to talk a little bit about a paper that we published last year about the state of massage therapy research, particularly with serious illness populations. And it's abysmal is really if I were going to choose a word, it's pretty bad. But there's some really serious guideposts that, the gaps show us very clearly where we need to go. So I think if there's hope, there's hope in that. So Marty, I don't know if you have questions that you want to start with, or
maybe you could give us a little bit of an overview of the evidence, even if it is abysmal, even if it is full of gaps. At least we can appreciate that there are them, and maybe give us a little bit of a sense of, if there are so many gaps, if the evidence is so abysmal, how can we be certain that this is something that really is helpful? I think that's a great starting point.
Yeah, absolutely. And this is the question. I mean, I think massage therapy has existed in a sort of nice to have space and continues to be in that space. No one thinks massage is not good, but when it gets to the question of, is it worth paying for, that's when the wheels kind of come off. And so, what we looked at in our narrative review, and what was unique about the review, is that we really looked at massage therapy research with seriously ill populations. There were no studies about palliative care populations and massage therapy. They were all diagnosis specific typically. And they really sort of plagued by small sample sizes, not adequately powered. There was a lot of variability between the studies. And when we sort of narrowed it down to studies that just focused on massage therapy and not aromatherapy massage or massage versus acupuncture or massage plus something else, it left us with a pretty small sample of studies. And there was wide variability in terms of, we sort of narrowed it down in the paper to 4 categories. And the first is study outcomes. So there really aren't novel measures to look at the impact of a complex psycho-emotional intervention like massage. Massage tends to be viewed as, earlier you said, Rachel, you're going to ask me later about how to get funding for modalities like blah, blah. We have to stop thinking of acupuncture and massage and music therapy as modalities. These are disciplines provided by providers trained in those disciplines. So sure, you could have a nurse do something like massage, but it's not massage therapy. And that's part of the conversation that we're trying to change. So when you look at the outcome measures, we look at, pain as a discrete measure, which is problematic. And we could talk about that a little bit. Even the quality of life measures typically include questions about things like spending more time with family, financial concerns, things that even the best massage therapy session is not going to address those concerns, right? So it sort of challenges the sensitivity of the tool. The other issues were that, and I hope this will be surprising to you. It was certainly surprising to me that in a majority of what we call massage therapy studies, the person providing the massage is not a massage therapist. It's a social worker, it's a nurse, it's the researcher whose credentials are unknown. And it's very rare that massage therapists are actually directly involved in creating massage therapy research and in executing it. So it just shows the broad disconnect that in people's minds, massage is rubbing. And that's not wrong. It's just insanely reductive, right? So massage providers was one of the categories where like, this is a major problem. If we're going to move massage therapists forward in serious illness care, we have to measure the impact of massage therapists, right? And then the population, of course, looking at who's getting massage. Typically speaking, in sort of the world, socioeconomic status tends to determine access to massage. And so most people are massage naive, so to speak. When you're in the serious illness space, we see a high representation of people with mid to low socioeconomic status. Massage isn't even on their radar. So the idea that they might even come in with preconceived notions about massage, like as a researcher, it's great because people are like, oh, massage? Sure. I mean, like, what else am I doing, right? I'm hanging out in the hospital. So when we look at like, so if we take outcome measures, typically there's a little bit of a debate in the massage world about, do we want to look at mechanism or do we want to look at sort of the more qualitative aspects of this? And, you know, I feel like personally, not surprisingly, working in the palliative space, I'm all about how does massage impact the experience of serious illness, the experience of hospitalization. And so I'm very excited if your salivary cortisol goes down. Yay. But so what, right? So what does that mean? And what do we do with that? But if I can show that by increasing your sense of peace, helping you cope better, that you are engaging with OT and PT more, that you are, you know, pressing your call button less often, that maybe you don't need that bolus right away when it's time. These are the kinds of things that we can show that, you know, morphine and massage, morphine's going to win every time if we're counting beans, right? So, but I, to my knowledge, have never caused a bowel obstruction, right? Yes, massage relaxes people, so maybe they'd rather sleep than talk, but they're not actually out of it in the same way that they might report feeling like with some of the opioids. And I want to be really clear. I am not, nor do I ever want to be in a cage match with opioids. Opioids have their place, highly valuable. I think it would be great for us to do some research about how can massage and opioids work together? How can massage, or how can opioids and music therapy, these sort of more complex psychosocial interventions, how can we use less opioids maybe, or sort of use them in a more intelligent and more sort of like thoughtful way in terms of how do we change the experience, that it's not about shutting down pain, it's about making it so you can be with the pain that makes sense based on the disease that you might have. And then, of course, when we look at pain, pain is typically measured on a Likert scale as a discrete symptom. And we all know that pain is a very complex experience, and it's also affected by other symptoms like anxiety, like shortness of breath, like constipation. And so if we don't start looking at symptom clusters, we're really missing a huge chunk. And I mean, that's true for all kinds of research, but I think particularly when we look at, you know, what are considered the integrative disciplines, we can't look at things in this sort of reductive way and think we're getting the most useful picture. So I really want to, we published a palliative care dosing study, massage therapy dosing study last year. We worked with a little over 400 patients, and we had 3 arms in the study. In the first arm, people got a single 20-minute massage. And then the other 2 arms, they got massage 3 days in a row. One group got 10 minutes, one group got 20 minutes. And what we found was that actually the days in a row was more predictive of support than the length of time. So 10 and 20 minutes was almost a wash in that 3 days in a row. And I think it really points to another gap in the literature, which is that, and even in the real world, if you ask around, I wouldn't say many, but there are palliative programs that have a massage therapist. Now that massage therapist may be a volunteer, which is a whole nother soapbox I can get on. Generally, they're not very well integrated as part of the team, but that person is maybe able to provide patients with a massage once a week, once a month. Are there any other disciplines that are providing the care they provide with that kind of frequency or infrequency? You wouldn't get OT once a week. You wouldn't get PT once a week. You wouldn't take your pain meds, you know, once a day. So people say, oh, well, the effects of massage therapy are short-lived, like every other thing that is standard of care to manage symptom burden, right? So that's not quite the ding that people are like, oh, well, it doesn't last. I'm like, when your morphine runs out, you need more morphine, right? And if, if the massage therapist can be there at the right time of day, for instance, like, could we help people with sundowning? Could we help people prepare for procedures? I and our therapists on our team have worked with people while they're having their wound dressing changed. There's so many places where we could be a part of care, and that with the proper training, a massage therapist is bringing exponentially more than their hands. They're noticing with their eyes things like skin breakdown, cellulitis, blood clots. And when patients relax in that way, even if it's for 10 minutes, we are like a bridge to the social work and chaplaincy team, because patients suddenly start telling us stuff that they haven't told anyone else, or they're now ripe for an advanced care planning conversation that a massage therapist with the proper training, rather than panicking, can say, tell me more. And then they can not close the deal on that conversation, but then that patient has started that, and they can report back to the chaplain, the social worker, or the case manager and say, while I was working with Mrs. So-and-so, she said she's ready to have this conversation, or like she's been worried about the DNR status, et cetera. Yeah, Marty.
Can I ask you to expand on that? Because we've had music therapists, OT, PT, speech, a variety of the therapy groups here with us. And one of the common themes we always get is that these are not volunteers, or I guess I would say is, sure, there are volunteer arms, but we are a discipline, we have expertise. There is a real rigorous training here. Can you tell us a little bit more about the training you receive and the things you're looking for?
Yeah, well, this is, I mean, wow, you just teed up one of the main issues that, we really struggle, because there's so many carts and so many horses, and we're sort of advocating for multiple things at the same time. Massage therapists who do what the massage therapists who work with Heal Well and who've trained with Heal Well do are very few. Massage therapists leave massage school basically trained to not hurt healthy people. We have a state license exam in almost all states. There's still 4 states that aren't even regulated. But beyond that, it's the Wild West in terms of how you decide to pursue continuing education. And I think because massage therapy is so poorly understood by, well, everyone, including massage therapists, hospitals are hearing that patients want this. So they're sort of going to the yellow pages, or the 2024 version of that, and just calling massage therapists who are so excited to work in the hospital and have no idea how much there is to know and how much the specific training. You can't just put a massage therapist in the hospital and say you're offering hospital-based massage therapy. The skills that go along with that have very little to do with hands. And so for the last 16 years, Heal Well has actually been providing in-hospital training for massage therapists, and that sort of advanced skill training when you look at like CAPC and other organizations who are advocating that all providers have the basic skills of palliative care, this is what we're doing for massage therapists. We're not teaching them a whole lot about massage. We're teaching them how to communicate, how to sit still with unanswerable questions, how to be part of a collaborative care team. I mean, massage therapists are trained as rogue individuals. We're going to go start our own practice. We're going to be in a room by ourselves with the person we're treating. We're never going to talk to anybody else about what we've done in that room. And so it's not even in our sort of perspective as we leave massage school, the idea that we would work with other providers. And there's also this kind of, if you don't go into massage school with it, I think a lot of people come out of massage school with kind of a low to mid-grade mistrust of mainstream medicine. So there's sort of this idea that going into the hospital or working in clinical settings is like working for the man, or sort of selling out. And I feel like the palliative care has been such a great home for us, because I feel like palliative care attracts providers too, who are like, what if we loved people and did it in a really like clinically effective way? So I think the gap between your average massage therapist who is doing valuable work, and this is the thing, it's not that we're better, we offer a different level of care. And so if you're, and our real struggle is that, as we all know, in America at least, lots of people are living with chronic and serious illnesses who aren't in the hospital, and they're getting affordable massages at franchises from massage therapists who don't know about blood clots and skin breakdown and the early signs of diabetes or COPD. And these are the gaps we're trying to close at Heal Well, so that regardless of setting, that massage therapist can potentially be a frontline provider, a collaborator in care for long-term care for early signs of chronic and serious illness, and to really be more than hands.
Maybe that's a perfect segue to get into Rachel's question. Do you want to ask it?
Sure. So my question is, how do we then really bring this information to the people who have the opportunity to say yes, to get massage more integrated into our therapies? I mean, you would be the perfect fit with speech and OT and PT, right? And like you said, palliative might be that little crack or that little door, because palliative providers are often already thinking about quality of life. We're already thinking about compassion. We're already thinking about listening and seeing that person as a whole being, not just their illness. So how
Yeah.
then do we advocate for your massage therapists to be here? And
Yeah.
how do we create a path for additional research? Because that sounds like it's a major need. And for a organization like Advocate Aurora, who is looking to do more research, maybe there's the opportunity to figure out paths forward together. I don't know.
Yeah, I mean, I think there are a number of avenues based on what a person is excited about in terms of how to make this reality. So absolutely, we need better funded, better designed research that really looks at how can we show the impact on patient experience, care, the essential outcomes with a properly trained massage therapist. That it's not about we rubbed, because one of the other limitations in a lot of the research is it's very protocol driven. So top of the foot gets massaged for 2 minutes, back of the leg gets massaged for 2 more minutes, so that in fact anyone could do it. And in our studies, what we see is patients saying, the reason this was great is because my neck was killing me because of a surgery I had, but I didn't want to have my neck touched. And the therapist was able to say, okay, what else can we do? And because the therapist was able to give the patient back that autonomy and work with another part of their body, which we're just a great big nervous system, that was still supportive to that patient. So better designed, better funded, appropriately powered studies is one place where we could use a lot of help that involve massage therapists. We are currently in the process of creating a national level palliative massage certificate program so that we can create this workforce of massage therapists. That is not a cheap endeavor. We started with some seed money from a grant, but we really need support to, it doesn't turn into jobs yet for massage therapists. So to make a multi-$1,000 investment in a year-long training program to be a volunteer, it's a hard sell, right? So we need financial support so that we can offer scholarships, so we can partner with hospitals to create jobs so that therapists who commit to this training can be in this place. And then we really need to just change the way we're thinking about this. Massage on paper will always be more expensive than lots of other things, right? But when we look at, so we did some semi-structured interviews with nurses last year who had worked with our therapists in an oncology unit and the sort of where LVAD placements and pulmonary issues happen. And what we found, it was, thank God for grounded theory approach, because the questions we started with were not where we ended up. These nurses unbidden said, when your therapists were on the unit, our workflow was better, patients pressed their call buttons less, we experienced less moral distress, because when a patient was struggling, I could send them a person instead of a medication or in addition to a medication. And so I was able to focus more on my work because I felt like I was meeting the needs of this patient. So looking at the indirect savings of having a properly trained therapist, these are the kind of creative things that I think we need to look at, and the investment of, you could hire a massage therapist as part of your palliative care team for $70,000, $80,000, right? And that person, based on the data from our dosing study, they could see 4 to 5 patients an hour. And this is part of the change as well, is it's not an hour of massage, which is what we tend to imagine, right? It's 10, maybe 20 minutes, and anything more than that with seriously ill patients, we're looking at diminishing returns. It's really, it can be taxing to be touched for that long.
That's really powerful, if you put it in that perspective. And it aligns so beautifully with like what our chaplains do in their work.
Definitely.
They're not spending hours with every single patient. They often just go in and do a prayer to honor that patient's cultural or spiritual needs, and then they can move on and support. But it really builds trust with that patient and with the healthcare system, but also with the team,
Yeah.
and it great for moral distress. That was one thing I was going to bring up if you had any information on that, because we often hear our nurses and our frontline staff being so stressed when the symptom management isn't going well. What
Definitely.
do you do? And I'm always the one who suggests, well, let's call the chaplain, and they're like, okay, okay,
Yeah.
try
Well,
everything.
and we often call ourselves undercover chaplains.
Are you an
Because
chaplain? Is
yeah,
that
because when the chaplain shows up, there's an expectation of like, we're going to talk about heavy things, right? But I'm just going to make you feel good. And the first thing I'm going to say to you is if anything I do hurts, tell me. And if you don't want a massage, you can say no. How many other things can you do that with, right? So, but then while we're working with a patient, all the things you're talking about often come up, and then we're able to bring that added value.
I've got a question for you in the chat.
Okay.
Tom has got two. So the first one is interesting because it's about virtual massage therapy, which on one hand seems counterintuitive, but on the other hand, you're talking about autonomy, space, awareness of total suffering. Maybe there's a role. Is there any role for virtual versus inpatient for therapy?
I don't know that I can speak to that. I don't really have any experience with administering that or receiving it. I know that, so with the home-based palliative care program that we partner with, we are the only part of care that isn't virtual. So that's maybe some version of this, is that everyone else on the team communicates with patients through the tablet, but our therapist goes into the home once or twice a week and is able to kind of have eyes in the home on the family, and anyone who's in the home receives massage. So if, there's a spouse caregiver, an adult child, whatever, anyone who's there who is interested in receiving massage gets a little bit of that. So, but yeah, I don't know about virtual massage. I mean, I think part of what we do and part of what we train our therapists is that the most important thing you're working with is the nervous system. You're not manipulating muscles and soft tissue. I mean, you are touching them, but what you're doing is actually creating a co-regulating environment for the nervous system, which can happen virtually. But I guess I would wonder, how would that work for massage therapy? It probably could, but I don't know much about it.
And then Tom has a second question. How does one harmonize with some of the ambulatory programs as part of the 4 M's, which is what matters most: medications, mind mobility, wound care, and sleep interventions?
Yeah, I mean, when I read, when the 4 M's like became a thing, I was like, oh my gosh, this is us. This is what we do. Like, and with the proper training, massage therapists could be looking at all of those things and collaborating. I think outpatient clinics are some of our most robust partnerships at HealWell, working with oncology clinics and palliative care clinics, whether they dedicate a room or whether we actually work with people while they're waiting for the physician, while they're waiting for the nurse, just kind of being a part of this care that makes them more receptive to the conversations that they're going to have. And I mean, this is the thing, we often do address discrete pain or challenges related to their illness. And a lot of times we're just making it possible for them to be in their body in a way that they weren't able before this very gentle and patient-centered intervention.
Another question that popped up in the chat. Somebody would love to hear you share a little bit about one of your most memorable patient encounters.
Oh man. I was just talking about this gentleman that I got to work with pretty early actually in my massage career. He was probably in his mid 50s, and he had been climbing up in his attic on one of those rickety, attic stair things. And his husband was out and he fell and broke his back. And so I was working with him, and, he's talking with me about falling, and what he's really talking with me about is like mortality and loneliness and brokenness, right? And I can feel that what's happening for him is like, I'm stuck in this bed, I'm aging, I'm no longer attractive, I'm all these things, right? And he starts crying, and he's like, don't stop because I'm crying. And I was like, okay, well, don't you stop because I'm massaging. And he kept crying and I kept massaging. And I mean, I feel like, yeah, my hands were helpful to him, but really, like, I wasn't afraid that I was like, oh, thank you for crying. And like, I want to cry too. And and real quickly, I will say there was another one that I was teaching just last year, and it was a new group of students, and we had just been talking in the debrief before we went to the units. What happens if somebody asks you, am I going to die? And, so we had the conversation that ensues, right, when somebody says that. The first patient I go into with these 3 students says, am I dying? And she wasn't dying right then, but I don't know if she was going to survive that hospitalization, right? And so it just, I felt like everything disappeared, right? And we were just in this place where she didn't want me to tell her if she was dying or not. She wanted to tell me that she thought she was dying, and it was scary, right? And so I was able to just like, I was massaging her hand, and when she asked me that, I just sort of like followed her breath and sort of like squeezed her hand like with her breath, and she squeezed my hand back. And I don't remember what else happened after that. But yeah, I feel like there have been so many like that, and especially in the children's hospital with parents and with patients, just yeah, where everything else just goes away and you're like, oh, right, like this is why I'm on the planet. Like we belong to each other, and I can't believe I get paid to do this job.
It looks like there's just one more question in the chat, but it's a multi-parter. I'm just going to read the whole thing, and you can
Okay.
pick and choose what you'd like. So,
Okay.
it says, I'm curious to what degree research looks at stratifying patients who benefit, and do dementia patients benefit, and can it affect readmissions, and is there a benefit for the caregiver? Which I think you covered some of the stuff a little bit, but
Yes is the shortest answer to all of those. I will say that, the question of benefit is such a curious question. We have a hospital-based massage therapy peer mentorship group, and we were talking just last week at rounds about contractions, and how particularly people with dementia and some of the neurological disorders will have contractions, and people who don't understand massage. And it's weird because they do understand the disease and what's causing the contraction. So it's a curious disconnect, but they want us to sort of open the person's hand. And it's like, okay, like, but their brain and their nerves have decided to keep that hand closed. So is benefit an open hand, or is benefit something that's a little more intangible? And so I think it is the rare case that a person doesn't benefit from the focused clinical attention of a properly trained massage therapist. If your rubric is about going home sooner, if your rubric is about less meds, like it's all about how will you define benefit. And I think that this is sort of the broad advocacy part of this message, is like, is paying a trained person who can also notice clinical challenges and outcomes and things to be present with this person in a focused way for 10 to 20 minutes on a regular basis worth paying for? I want you to tell me to my face that that isn't worth paying for. So I think it's definitely a challenge. Stratification, we wind up stratifying because there aren't enough of us. So typically we look at people with the highest symptom burden, people who are reporting pain, and with caregivers, particularly we see in the children's hospital, a lot of the kids will say, no, I don't want a massage. But then you see the kid go to sleep because we're massaging the parent, especially with the kids who are old enough to kind of notice the burden that their parents are carrying by being in the hospital. Or the kid will say, I don't want a massage, or will you massage my big toe? And so we massage their big toe. And then the next time we come back, they're like, okay, you can massage up to my knee now. But that the parents feel the benefit of us even just massaging the patient. So I think there's a symbiosis with caregiver massage, but also just a straight up direct benefit. Our home-based palliative patients and their spouse caregivers and adult child caregivers are like, wait, I get a massage too? Okay, but only 10 minutes because I don't want to take it from, my whoever the patient is considered the patient. So that also takes a while, but once they accept it, they both look forward to it, with the same excitement.
I think this is so magnificent and so powerful, and I'm so glad that we were able to make this introduction and learn more. Cal, if there's ways that we can help connect and get, can I get a massage therapist here, please?
Yes, yes.
I want one. We need
and
one.
And we
Please.
do partner, we do consulting, we work with training. If you already have therapists who don't have this kind of training, we work with providing that training. We can help talk about how to get them, how to get them into the electronic medical record, all the pieces of like, how would this work? We've been figuring it out for 16 years. So if we can shorten anyone's curve, that's why we exist.
Yeah. And I also think one thing that you mentioned about connecting and building that trust and the power of listening. There was a quote once I heard that said, listening is being able to be changed by the other person. That's how you know you listened. And I think a lot of what I heard you say is that massage slows everything down a little bit so we can actually listen and honor that patient in such an appropriate way. And so I'm really glad to hear that this research is being done. I'm really glad to hear that this essential work is taking small steps forward. So thank you so much for being here.
Thank you all for being here.
The audience, Cal did put their email in the chat, so you can get a hold of them. And I guess maybe when you publish again, we'll have you back to hear the updates and
Sounds
hear
good.
what's going. So
Right.
thank you so much.
Thank you all.
And has a beautiful Friday. Take care.
Good work.
Be well. Bye.
Bye.